Hello, Replantations, and welcome to another case review. This is Ali Nasser, and I'm joined again by Dr. Derek Grzanich, endodontist and educator practicing in Houston, Texas. Dr. Grzanich, thank you again for joining me.
Thanks again for having me.
So, this is a multi-part presentation on intentional replantation. We already did one case one. So why don't we come back and why don't we do the case two now that you prepared for us, where we can talk about the way you managed this case and you went on. So having said that, why don't you go ahead and present your case two for intentional replantation?
Yeah, so this patient was, she was referred for retreatment of tooth number 31, and that was due to sinus tract. She had pretty good oral hygiene. She was seen in July of 2014 for a consultation, and we took diagnostic images as well as tests. And we also took a cone beam 3D image at that visit. So you can see in the image here, the tooth has a nice crown over it. The endo looks okay. I mean, I don't see any big issues with that, but you can see a huge separated instrument as you start to go around the curve in the mesial root, and you can also see the lesion that started. So this is just another angle of for this case, for this tooth. And we took the cone beam here, and you can clearly see a very extensive lesion. That's what's been pretty amazing with our cone beam X-rays. Is sometimes you can even, pick out images with lesions you couldn't even see on a periapical image. But you can see here how extensive this lesion is. And then in this case, we pretty much determined that instrument retrieval was not going to be real feasible just based on where it's at and based on the amount of tooth structure that we would be that we'd be removing, trying to remove that. And the thick buccal plate in this area was going to make the apical surgery very difficult to perform. So, as with any other sinus tract that presents in endodontics, we trace it with gutta percha, so we're 100% sure of where that lesion is coming from. This intraoral picture shows us the sinus tract off of the buccal there, how big that sinus tract was, and that's where we did our sinus tract tracing. So in this case, we removed it. We went ahead and took the picture here. You can see the gutta percha and the distal root, and then right to the apex, or maybe a little extruded. On the mesial, you could basically see where the instrument was sealing the apex there, no gutta percha exposed. So we went ahead, we did our staining to make sure that we weren't seeing any root fractures. In this case, we did not see any root fractures. And we went ahead and under saline irrigation here, we went ahead and did our root resection. And you can see the gutta percha there in the distal root, and the mesial root, you can see it's a little open, or maybe a little bit where the file was kind of sealing that apex. So after we had cleaned it with the handpiece, we cleaned it with our ultrasonics, just like we do all of our other cases. We got it ready to seal by packing in our BC sealer, BC putty, our root end repair material. And here you can see us with some dampened gauze, just kind of removing the excess. And upon reinsertion, we go as far apical as possible, being careful not to touch the sidewalls where the cells were. But we went as far apical as possible just to stimulate some bleeding. It's almost the same principles of an extraction. We didn't necessarily, we just wanted to make sure that we weren't going to have a dry socket. And the blood, the bleeding is basically our first step in the healing process. During the extraction, this crown did come off this tooth. It was kind of a good thing because I actually noticed some decay on the distal lingual aspect that we wouldn't have seen had the crown not come off. So this is immediately after reinsertion. And in this case, we did not re-cement the crown. And the patient was scheduled back in a week for evaluation. So this is our x-ray post-op. So you can see our BC putty sealing the apex quite well. And the tooth was left without the crown, so it was not in occlusion. So at the 1 month follow-up here, a couple things that we can know. One, which was pretty amazing, is you can see that huge lesion, the sinus tract that was present at the preoperative day, has completely healed. And you can see that this patient has had a nice prosthetic temporary made to keep number 31 protected while we're still waiting on the healing process. And this patient definitely didn't want to invest in a new crown until things were healing from the reimplantation. So we saw her back in about 3 months. So that's typical for these follow-ups. I like to see them in a week, then I like to see them in a month, and then I go to the 3-month, the 6-month, and then we start to do annual recalls. So here's just another picture of the 3-month, which was pretty miraculous to start to see bone filling in already in that area of periapical radiolucity starting to heal. And here's the 8-month, which you can see even more bone filling into that apical area, and we're starting to see some pretty good healing already, which is very encouraging. And then this is at 14 months. This is an X-ray without the provisional crown in place. She was going to go see the prosthodontist after seeing us, where they were going to refine the prep and get their final impression for the permanent crown. And this image is a little rotated, but this is a cone beam X-ray. And if you compare this 3D to the first cone beam we had for our preoperative diagnostics, it's pretty amazing to see the healing that we've seen and the amount of bone that's filled in. So, you know, we have some literature. This is not a new procedure. This dates back to many decades ago. But the main thing is this is our last treatment option to save a natural tooth. And every case we treat the same. We go through the pre-rinse with the Paradex. We have the post-op prescription for the Paradex. We're just trying to eliminate any bacteria that could be hindering the healing process. During the whole process, we're holding the tooth with the gauze that's saturated in the Hank's mouth salt solution, that Save a Tooth kit. And when we're not working on them, we keep it in that Save a Tooth kit. On here in the literature, it says extraoral time no more than 20 to 30 minutes. I think that's a bit much. We tried to be in the 5 to 10 minute range, but this time is what they had, I guess, as a maximum time that they had kind of reported in the literature. But again, if you can limit it to that 5 to 10 minutes, you're going to have much greater chance of success, and you're going to have much better PDL cell vitality. And it's important during the procedure not to touch the walls of the socket. And if you have to curette, just to go as far apical as possible if you want to sample for biopsy. As with endodontics, every tooth, every procedure, we're working under that microscope. We can inspect it, and we stain these teeth for the fractures, as you've seen in the intraoral photos we had taken. Most of the time, you don't need a splint. Occasionally, you do need a splint. In this case, we did not have to splint. Again, sometimes suturing is required. It just really depends, but most of the time, suturing is not going to be required either. We do recommend NSAIDs for pain control, 600, 800 milligrams, Advil, Motrin, ibuprofen, whatever brand you have is what we recommend for any post-operative endodontic care. Antibiotics, usually not necessary. In the literature, it's been reported that if you do use antibiotics, to maybe look at using something like doxycycline, might be less of a chance of resorption by doing so. So this piece of literature is from Bender. This is from a study in '93 where success rate was at 80.6%. There's a meta-analysis out from Benajad that tells us we get about 88% success reimplantations, and that was a meta-analysis comparing reimplantation versus implants. There's also a study I just read in it was either June or July of this year, 2016, JOE, that shows about a 93% success with intentional replantations, and that was over a 12-year follow-up. So that's pretty impressive, results for teeth that most of the time would have just been marked for an extraction. I would much rather have my natural tooth for 12 more years than go right to an implant. And these survival studies, it varies, but they've been reported up to 22 years. Location, it's the mandibular first molars, mandibular second molars, and then we get in kind of the premolar area. Not that common in maxillary molars, just based on, it's just based on the anatomy. The best ones are those conical shaped roots. So more from the Bender and Rossman study. They say the performing when the apex is in close proximity to the mandibular canal or maxillary sinus, that just preventing any paresthesias, sinus exposures, things like that. Although that's it's not a situation where if you have the sinus exposure, it's going to lead to failure of the case. As we do get good healing. This procedure is performed a lot of times if treatment or apical surgery doesn't eliminate the disease. It's advantageous if you have unknown etiology, maybe think that a fracture might be present. Again, you could always perform the root resection wherever that fracture may be. It's a situation where if it's fractured beyond repair, you would just leave it out, what the patient was going to have done anyways. It can be indicated when there's a separated instrument, which can't be removed or bypassed. And basically, at that point, it's about preserving dentin. It's preserving the strength of that root. And it can be performed if there's perforations as well in the root. Contraindications from this Bender and Rossman study: presence of periodontal disease with tooth mobility. You're not going to get as good of results. The furcation involvement, again, this isn't going to help heal furcation involvement. You got to be careful if there's gingival inflammation. Sometimes it's combined endoperiodontotherapy. And if the roots are long and curved, it would most likely fracture during extraction. That's another contraindication for the intentional replantation procedure. Definitely the patient needs to know the risks. So tooth fraction during extraction. You tell them, hey, we're going to do everything we can to get this out of there without fracturing, but there's a chance. So it's really about informed consent. It's about the patient fully knowing what you're doing. You kind of talk them through the procedure from the beginning. They have to know that the crown of restoration can break during the procedure and needs replaced. This happens more times than not. These teeth are usually heavily restored, and a lot of times it might require them to have to get a new crown. But having this procedure and getting a new crown is going to be cheaper than going right to the implant. It's going to help them retain that natural tooth. Some of the risks: we have the risk of resorption. We have the risk of ankylosis. Again, if this tooth is going to be saved, those aren't necessarily the worst thing in the world to have happen, especially the ankylosis. The oral surgeon, periodontist may hate us, but it's not necessarily meaning that the tooth is going to fail. We could get great success from this procedure. Some of the literature, there's literature that goes that some orthodontists have actually, before we've done this procedure, we have kind of preoperatively for 2 to 3 weeks, we've kind of basically superpositioned the tooth. We just kind of extruded it just to kind of loosen up that ligament space. It's definitely shown very good success when we've done this, but it's also added cost and time for the patient that they may not be interested in. For maybe, I've seen anywhere from 2% to 10% greater chance of success by going through this preoperative orthodontic extrusion. Again, risks: there can be future furcation involvement, future bone and attachment loss. And you pretty much have to know this is not the first treatment choice. But the tooth prognosis for these cases is almost hopeless to start. So, if you're willing to go through it, the patient's willing to go through it, we've seen some very nice results noted throughout the literature throughout time.
Yeah, thank you. Yeah, I agree. I think the key to emphasize here is that it's not the first treatment of choice, because there's certainly, risks associated with it in terms of the extraction, the dislodgement of the crown, the breaking of the crown, the breaking of the root, all kinds of different things. If it does come out intact, then you have the odds that have been indicated in the literature in terms of it working out well. But that initial risk of root damage and all kinds of problems that could happen makes it not so much a replacement for apicoectomy. Apicoectomy is still the proper treatment option for teeth with endodontic or persistent disease that cannot be remedied through revision non-surgically. Apicoectomy would be the next choice. And then, as you mentioned, that the intentional replantation is really an option as a last resort for a tooth that would otherwise have to be extracted. And the patient who's motivated, who's willing to go through this step to try to save the tooth. I think in terms of the teeth that I usually try in my office, as I mentioned, are teeth that I can't access surgically, and those would be primarily mandibular second molars, where you end up running the risk of damaging prealveolar nerve problems and having too much bone to get through, where they have the idealized type of a root shape being conical, where you can get easy atraumatic extraction. And also some of the teeth that might be helpful, Derek, I find are mandibular second premolars, for example, or first premolars, where the mental nerve is immediately adjacent to the apex of the tooth, so that apicoectomy would be a high risk for such patients. And mandibular first and second premolars being fairly conical roots, they're easy to extract and replace. Have you? I know you've done a couple cases with those as well. Have you had good experiences with those teeth?
I have, and again, it's an importance of, a lot of times it's the importance of us having access to that cone beam now that's going to show us basically where the mental nerve is, and basically in relation to those premolars. We'll see in a future case that we'll do in this series of a premolar that when the patient presented to me, it was basically her last hope. She had went through endodontics, she had went through a retreat, she had a nice crown with basically what I felt was an oversized post that shouldn't have been in there, and she didn't want to go through basically any more treatment on that, through that crown. She had just invested all this money in this crown, and she'd actually had an apico performed on the tooth, and it still wasn't healing. And so this became the last chance of her to save this investment, and that's really for her what it had turned into. She's like, look, I paid for a root canal, I've paid for the retreatment, I've paid for a brand new post and crown. It's like, I've went through the apical surgery, and she's like, hey, I know this may be the last chance to try to save this tooth, but I'm willing to go through that. And again, it was a tooth that didn't have great, root length. It was definitely almost a 1-to-1 crown to root ratio, but you will see in the presentation that we present that we have a 12-month follow-up of healing of this tooth. And is it going to last the rest of her life? I mean, maybe not, but it's definitely lasted her another full year of this investment.
I think like any other endodontic cases, the key comes from the coronal. If it works well over the first couple of years, it could potentially last a lifetime, as long as you have a good coronal seal and you don't have any coronal leakage coming up. I think the longest intentional replantation case that I have on record right now is over 20 years. And it's a lower second molar, and it's still working fine for this patient. The key again is to use the right indication. Do you not do much, because this tooth was the first molar, obviously there was a broken instrument in there, so I'd like to ask you first, what are some of the cutoff points for you to attempt to remove a broken instrument non-surgically? And also, do you not do apicoectomy on first molars? Because usually I found also the same way on first molars, because of their potential divergence of the roots, some of them are more difficult to replace back in. Where is your surgical thing for doing apicoectomy on a first molar versus doing intentional replantation?
Well, again, I'm very much pro surgery. So I mean, when I think through cases, the first thing I think about is retreatment. You don't know where the treatment was done. You don't know if a rubber dam was used, what irrigations were used. So, the first thing I think of is retreat. Then, if you're like, well, I don't know if a retreat's going to really help heal this tooth, or you think you could damage the crown, or you can break, root going in and doing it, then you start to think down the surgical route. So in this case that we just talked about, that was a second molar with that broken instrument. And so that root structure, it was it looked like one that we could remove without much of an issue, just based on how it was positioned. And in that case, we were like, well, she had a nice crown on the tooth, but by the time you get in there, sometimes I'm very conservative in my approach. So I feel, and even in my preparations, I try to control the taper. I don't want too much, I guess coronal taper, or even taper all the way through the tooth, because you can't replace that dentin. Once it's gone, it's gone. And every time you're in there, you lead to more weakening. And, with all the, with different root fractures and vertical root fractures and things like that, I always try to think through not just the immediate procedure, but I always try to think through, I guess, hopefully the most conservative way to get healing. So, it's basically where an instrument's broken and when it's broken. And, in that case, that was a huge instrument, and it was right around the curve. And we could see it on the cone beam that the risk of us going in and trying to remove that, possibly root perforation, root fracture, things like that, in my mind, it was just not worth the risk in this case to go through that route.
Yeah, I mean, it seems like anything else, based on our level of comfort with different aspects, we end up, recommending the treatment that we have experience with. I agree with you. The key is to keep the big picture in mind, have the patient's best interest in mind, and then make treatment recommendations based on what you think would be best for the patient. In this case, it turned out very well for this patient, and I think once they get the final crown and have proper coronal seal, the tooth could last a very long time for them. So, Dr. Grzanich, thank you so much for joining me today and sharing this expertise. We'll come back and do more of these videos on this very important topic.
Great. Thanks for having me.
I was joined today by Dr. Derek Grzanich, a faculty member at the OSF GPR program in Peoria, Illinois, and also adjunct faculty at the University of Texas Health and Sciences Center at Houston School of Dentistry, and also in private endodontic practice in Houston, Texas. For Replantation, I'm Ali Nasseh, and I hope you found this information helpful.